went to. But there was, you can guess who was the one person in the group, in the attendance at the meeting, that you could identify from 100 feet away based on his clothing.
Yes, Dr. Sun is familiar with that. She worked with him for a year at Duke. You're talking about Rick Bedlack?
Yes.
Yeah. Yeah, it's always fun to see what he's wearing.
That's unusual. Usually neurologists wear a uniform of a blue blazer, gray pants, and a light blue shirt with a red tie.
With a bow tie.
Or a bow tie.
That's right. That's how you pick out the neurologist, is the one with the bow tie. Yeah. It's a very prominent group that they have. I mean, these are kind of the leaders in the ALS community, at least in the US. All right, how many people do we have on now, Lilia?
15 people. And it's 8 o'clock, we can start.
15, all right. Okay, so good morning to everyone. Welcome to the first 2024 Neurology Grand Rounds. We've had patients in the hospitals who have an acute onset of weakness, acute ascending paralysis, and then we see people in the clinic who have a chronic, relapsing, remitting form of demyelinating neuropathy. And sometimes we see people who are somewhere in between. So not AIDP, not CIDP, but I guess we would call it SIDP, a subacute inflammatory demyelinating polyradiculoneuropathy. And so we are very fortunate today to have Dr. Sun, who is an assistant professor in Lexington, UK. She's been there since July of 2022. Before that, she did a neuromuscular medicine fellowship at Duke University with Rick Bedlack, who has very interesting wardrobe. And before that, she did a neurology residency in Worcester, Massachusetts. And so she's going to talk with us today about inflammatory demyelinating neuropathies, or inflammatory neuropathies, and sort of an update on those, and how it's more of a spectrum, I guess, than a black and white fine line between one and the other. So thank you very much, Dr. Sun, for presenting for us today.
Thank you, Dr. Brown, for the kind introduction. And it's my great honor to be here today. Let me share my screen here. Okay. Now, can you see my screen all right?
Yes.
Great. So as Dr. Brown mentioned, today I'm going to talk about GBS and CIDP. I do not have any conflict of interest, but I will discuss off-label use of medications. This is a very clinically oriented talk. I will start with the basics of GBS and CIDP, including their classic natural course and treatment strategies. Afterwards, I will present a challenging case which I saw last year in August in the inpatient service. And with that case, we will spend the majority of time discuss severe GBS, GBS treatment-related fluctuation, acute onset CIDP, and recurrent GBS. So GBS was first reported in 1916 by doctors Guillain-Barre and Syndrome. They reported 2 patients with motor disturbance, diminished tendon reflexes, and paresthesia. They also highlighted the feature of albuminocytological dissociation in CSF analysis. Later, we just used Guillain-Barre syndrome to suggest acute inflammatory immune-mediated polyradiculoneuropathy. But somehow Dr. Stroh's name dropped off the eponym. I guess it just tells us how important it is to be the first 2 authors of a paper. Okay, so GBS is a heterogeneous condition. Based on the electrodiagnostic features, GBS can be classified as acute inflammatory demyelinating polyneuropathy, or AIDP. And there's also axonal form of GBS, including acute motor axonal neuropathy and acute motor and sensory axonal neuropathy. There is also a separate entity of GQ1B syndrome with different phenotypes, including Miller-Fisher syndrome, Becker-Staff brainstem encephalitis, and the pharyngeal cervical brachial variant of GBS. Ophthalmoplegia is a common feature here because GQ1B is present in the oculomotor nerve. In addition to pathophysiological heterogeneity, GBS presents with phenotypical heterogeneity as well. The symptoms of GBS can be classified into motor symptoms, sensory symptoms, decreased consciousness, and ataxia. Classic GBS typically present with sensory and motor involvement in the upper and lower extremities, as shown here. But there are also cases of pure motor GBS and pure sensory GBS. And there are cases of GBS involving only the upper or lower extremities. But it is important to know that symmetry of symptoms is the common feature across all the phenotype here. So despite the pathophysiological and the phenotypical heterogeneity, GBS is a monophasic, self-limiting disease. Patients usually recall an infection 4 to 6 weeks prior to symptom onset, as shown in the red line here. And following the infection, the immune system initiates a response, leading to the damage of the nerves and the subsequent manifestation of GBS syndrome, as indicated in the green line here. So, but within a time span of 4 weeks, the disease reaches its most severe status, also known as disease nadir, and after which a highly variable period of stability follows, and subsequently the recovery phase begins. Typically, the recovery phase begins within 2 to 4 weeks from the nadir, although it can be delayed up for 6 months. But thankfully, the majority of patients experience complete recovery within 6 to 12 months. And it is very crucial to remember the 4 weeks time point here in GBS. This is a picture lists the diagnostic criteria of GBS, including features suggestive of GBS, features support the diagnosis of GBS, and features kind of mitigate the diagnosis of GBS. I would like to draw your attention that normal results from diagnostic workup, such as CSF protein elevation and normal electrodiagnostic studies, do not exclude the possibility of GBS. Therefore, GBS is primarily a clinical diagnosis. Although GBS is a self-limiting process, immunotherapy, such as IVIG and plasma exchange, are available to accelerate the recovery process, and IVIG and GBS are equally efficacious. Multiple clinical trials have failed to demonstrate the benefits of steroids as a standalone therapy for GBS. Therefore, steroid monotherapy should not be administered to patients with GBS. So 2 review papers are of great educational value in GBS. One is this Nature review paper published in 2019. And the other one is the European Academy of Neurology Peripheral Nerve Society guideline, which was just published a few months ago. And this same association actually published a CIDP guideline in 2021, which we'll discuss later in the talk. So that's all for now for GBS. What about CIDP? Dr. Peter Deck and colleagues coined the term CIDP in 1975. In this report, they reported CIDP's phenotype, including monophasic deficits, patients with recurrences, and patients with a steady or stepwise progression. They also described the electrophysiological and pathological findings in CIDP, such as slowed conduction velocity and segmental demyelination. There is a wide range of prognosis in CIDP, ranging all the way from completely recovery to wheelchair-bound to even death. This is another case series that has been cited frequently. This case series included 92 patients who were diagnosed with CIDP, and the report, for the most part, matches the findings reported by Dr. Deck. But interestingly, within this specific group of patients, there was a rapid rate of onset in about 16% of the patients included. Later, CIDP is defined as a chronic immune-mediated polyradiculoneuropathy that progresses beyond 8 weeks. So typical CIDP is just the chronic counterpart of AIDP, which causes both sensory and motor symptoms affecting the proximal and distal segments of all 4 limbs. Hyporeflexia or areflexia are commonly observed. In addition to this typical presentation, there are also CIDP variants, including distal CIDP, multifocal CIDP, focal CIDP, among many others. Each of these CIDP variants have its characteristic electrodiagnostic features, which we will not talk today. It is beyond the scope of today's talk. So as elucidated in the initial report, the clinical course of CIDP can be highly variable. 3 types of disease progression has been described. A monophasic cause, in which patients progress to their nadir, then fully recover with treatment, and usually do not relapse. And there are also relapsing remitting course, in which patients have complete remissions in between relapses, and a chronic progressive course, in which patients progressively deteriorate until treatment is given. The relative proportion of each of these disease courses varies greatly between different case series, mainly because the differences in the definition of different forms. But overall, about 20 to 35% of patients with CIDP have the relapsing form, whereas anywhere from 7 to 50% have the monophasic illness. So the diagnostic criteria of CIDP have been established and delineated by the European Academy of Neurology and the Peripheral Nerve Society, but it is not uncommon for misdiagnosis to occur. In fact, there is a significant body of literature focusing on the misdiagnosis of CIDP. I guess my colleagues in the neuromuscular division, like Dr. Brown, can attest how frequently we encounter cases where a CIDP diagnosis is later revised to something else, and how frequently patients who are labeled as having refractory CIDP turn out not to have CIDP at all. So again, I will not bore you with the exhaustive details of the diagnostic criteria and the reasons for misdiagnosis. But I guess the significance of accurate diagnosis cannot be overstated, because long-term immunotherapies are involved in CIDP treatment, and they are not without risk. This guideline did propose a treatment strategy in CIDP. In a nutshell, the approach involves induction therapy followed by maintenance therapy. And one interesting point here is that while steroid monotherapy is ineffective in GBS, it can serve as both induction and maintenance therapy in CIDP. And keep in mind here, the guideline did mention that if patient does not have any objective improvement with treatment, then the diagnosis needs to be reevaluated because a lot of times patients do not respond to treatment, not because they have refractory CIDP, but rather CIDP is not the correct diagnosis. Also, the differentiating between GBS and CIDP is crucial because of the divergent prognosis and treatment approaches in these 2 conditions. And although the clear-cut time marks of 4 weeks of GBS and 8 weeks for CIDP may seem quite straightforward, in real-world clinical practice, we often encounter very challenging cases. So I will share a case with you all today. So this is a 52-year-old woman who I saw last year in the inpatient service. So she developed weakness in the arms, which rapidly progressed to the legs associated with some paresthesia. She presented to the outside hospital first. Lumbar puncture showed normal protein, no WBC, MRI neural axis with and without contrast was normal. So she was started on IVIG for a 7-day course. Despite IVIG, her condition continued to deteriorate, leading to her transfer to University of Kentucky. On arrival, she had severe weakness in all 4 extremities, with strength measured 1 out of 5 in the arms and 0 out of 5 in the legs. And the second course of IVIG was given, but she didn't have any immediate improvement. And she was actually quite sick at that time. Her hospital course was complicated by respiratory failure requiring high flow oxygen and hyponatremia, likely secondary to SIADH from Guillain-Barre Syndrome. But fortunately, a few days after the IVIG, her strength began to recover, and she was discharged to a rehab facility with a muscle strength of 2 to 3 out of 5 in the arms and 1 out of 5 in the legs. So she initially continued to improve at the rehab facility, but 45 days after symptom onset, she was sent back to the clinic because of worsening muscle strength. But at the clinic, her strength was still mostly 2 to 3 out of 5 in the arms and 1 out of 5 in the legs. And after careful consideration, I actually sent her back to rehab directly from the clinic. And I last saw her about 4 months after her symptom onset. And at that time, she had a remarkable recovery. She was able to walk with a cane and was able to complete most daily activities. So as we can see for this patient, the disease course was quite lengthy. I think the first decision-making point is here. So there was no improvement observed following the first course of IVIG, and her symptoms actually continued to worsen with IVIG infusion. So is this unusual? So as a matter of fact, about 40% of patients treated with IVIG or plasma exchange do not show any improvement within the 4 weeks following treatment. But the absence of immediate improvement does not necessarily imply treatment ineffectiveness, as the disease progression may have been even worse without therapy. But what do we do if symptoms fail to improve? Since the only treatment options are IVIG and plasma exchange, we really have very limited options. I guess we could either switch to a different immunotherapy, repeat the same immunotherapy, or maybe add on some other treatment such as steroid. So let's start with the switch. I guess conceptually switching makes sense because the rationale behind this approach is that IVIG and plasma exchange likely have distinct immunomodulating effects, which may impact treatment efficacy on the individual basis. But does that really work? So this is a retrospective study revealing the course of 46 patients treated for GBS in a single center. Patients were divided into 4 subgroups based on treatment received, including IVIG, plasma exchange, IVIG followed by plasma exchange, or patients received neither therapy. ST here stands for symptomatic treatment only. So the mean disability score at admission, which was the first column of each gray color here, are about the same for all groups. But the disability grade on discharge were higher in patients who received plasma exchange following IVIG. There are two potential explanations for this observation. Firstly, it could indicate a more severe disease course in patients who received both treatments. But more importantly, it is very possible that plasma exchange washes out the effect of IVIG, thereby hindering its therapeutic effects. The study also revealed that for patients who received IVIG and plasma exchange had longer hospitalization and incurred higher treatment costs. This study suggests that switching from IVIG to plasma exchange may not be a favorable approach. So if switching doesn't work, if switching from IVIG to plasma exchange doesn't work, how about switching from plasma exchange to IVIG? So in this randomized controlled trial, a total of 388 severely affected GBS patients were randomized to receive plasma exchange, IVIG, or IVIG after plasma exchange. So it is worth noting that in this study, all the patients who are randomized to receive IVIG after plasma exchange received IVIG regardless of their recovery status after plasma exchange. But really, no trial has been conducted to show whether patients who truly do not respond to plasma exchange may respond to IVIG. So this trial is the best we have so far to answer the question whether IVIG following plasma exchange show any therapeutic benefits. But this trial did not find any significant differences between the three treatment modalities in any of the outcome measures. Therefore, adding IVIG after plasma exchange was not found to be superior to IVIG or plasma exchange alone. So if switching therapy doesn't work, how about treating the patient with the same immunotherapy for another course? So this research letter described the clinical course of 4 GBS patients who received 2 courses of IVIG during their illness. Arrow here marks the first course of IVIG, and the gray rectangle here marks the second course. So let's use patient 1 as an example. So this patient has symptom onset and then had a worsening disability grading scale. And then he received the first course of IVIG without improvement of the disability grading scale. And his disease plateaued, and then he received the second course of IVIG, and the disability scale improved. And similar trends were seen in all 4 patients here. We can see in patient 2, it's still getting worse. First dose of IVIG, no improvement. Second dose of IVIG, and then the disability scale improved. The same trends are seen in all 4 patients. But this study was not controlled, and it was not possible to determine whether the second course of IVIG contributed to clinical recovery. But to better understand this observation, this phase 3 double-blind trial was conducted in Netherlands. In this study, 99 patients with poor prognosis of GBS received IVIG first, and then they were randomized into 2 cohorts to receive a second course of IVIG versus to receive placebo 7 to 9 days after receiving their first dose of IVIG. The two groups did not differ significantly in the primary or secondary outcomes. We can see the adjusted common odds ratios are all over the map here, all including the magic number of 1. Moreover, the risk of serious adverse events, including thromboembolic events, were higher in patients with who received a second dose of IVIG. So this study provides strong evidence that for patients with GBS who fail to improve or continue to worsen after a first dose of IVIG, a second dose is not effective and actually they increase the risk of serious adverse events. So if extra IVIG doesn't work, how about extra plasma exchange? So this study randomized more than 500 GBS patients to receive different sessions of plasma exchange based on clinical severity. In the mild group, where patients were able to stand up unaided, 2 sessions of plasma exchange were found to be more effective than receiving no plasma exchange at all. And in the moderate group, where patients were unable to stand up unaided, 4 sessions of plasma exchange were found to be more beneficial than 2 sessions. But in the severe group, where patients required mechanical ventilation, 6 sessions of plasma exchange did not provide additional benefits compared to 4 sessions. I mean, considering for the most part, we gave patients 5 sessions of plasma exchange to begin with, it seems like repeating plasma exchange is not a good option either. So what about adding on some steroid? I mean, steroid monotherapy is not efficacious in GBS, but based on the mechanisms, if we truly think this is an inflammatory process, it's possible that steroid could reduce some inflammation and provide some beneficial effects. So this is a double-blind, placebo-controlled, multi-center randomized study that enrolled 233 patients. All patients received IVIG first, and then they were randomized to receive either steroid or placebo within 48 hours of administration of the first dose of IVIG. This study did not note a significant difference in patients treated with steroid on top of IVIG. So based on this, adding on steroids does not seem to work either. So just to summarize, when symptoms do not improve, switching to a different immunotherapy, repeating the same immunotherapy, or adding on steroid does not seem to be efficacious. So it is really not a matter of I don't want to do anything, but rather I just want to do nothing. So recall this patient's symptom worsened at rehab at day 45 of symptom onset, which is 40 days from the first course of IVIG and 30 days from the second course of IVIG. She was seen in the clinic for an urgent evaluation. I guess the first and easier question is, at this point, the patient worsened beyond the time mark of 4 weeks. So should we revise the diagnosis? Is this really GBS? Anyone? Any takers? I guess the answer, oh, sorry, go ahead.
I was just going to say everyone's giving an answer, but their microphones are turned off. So.
Oh, okay, sure, of course, yes. Yeah, I agree with everyone. I think the answer is no, because although her symptoms worsened at day 45, she was at her worst at day 11 of symptom onset. As shown here, she was quite sick, 1 out of 5 in the arms, 0 out of 5 in the legs. This is her nadir, and this is well within the 4-week time mark. Afterwards, she actually had a static clinical course where she was stably bad from day 11 to day 19. And this is the static course that was shown in the green line in one of the disease course picture. And then at day 20, she started to improve. So the diagnosis of GBS is still accurate. So if that's the case, the next question is, why did the deterioration happen? What is going on here?
Yeah, this is Dr. Wang. I have a question about the case.
Yes.
Any electrical diagnostic study on this case?
Yes. Well, so no, at outside hospital, she didn't have any. And while she was at UK, she was quite sick. She was in ICU. So with that environment, we didn't do any electrodiagnostic testing on her, actually. Any other questions on this one? Okay. So I guess the question is, why did the deterioration happen? So patients with GBS who have received treatment may show a secondary deterioration after initial clinical stabilization or improvement, which is termed treatment-related fluctuation. Treatment-related fluctuations have been reported in up to 10% of patients with GBS treated with either IVIG or plasma exchange. Typically, treatment-related fluctuation is not as severe as the initial progressive phase of GBS before the treatment. But what else do we know about treatment-related fluctuation? So this is actually the best we get. This is a case series published in 1991, and they described 10 patients with treatment-related fluctuation. We can see the fluctuation occurred anywhere between 10 to 60 days after the initiation of immunotherapy, with a median of 21 days. The mechanism of treatment-related fluctuation has not been elucidated, but it has been hypothesized that the effect of treatment is transient while the disease activity continues. And the treatment-related fluctuation therefore provide evidence that the treatment in a specific patient is effective, although not lasting long enough, and that the patient will probably respond again after repeating the same treatment. Therefore, it is rational to treat a patient with treatment-related fluctuation with a second course of same immunotherapy. But in this cohort, patients 1 to 6 received a second course of immunotherapy, and patients 7 to 10 didn't. But they all improved spontaneously following their relapse. And the two groups had a comparable clinical course. This actually indicates a relatively benign course of a treatment-related fluctuation. But again, the sample size is just so small and no randomized control trial has been conducted to study whether a second course of immunotherapy is beneficial in treatment-related fluctuation. Recall that the second case series that published 92 patients described 16% of patients with CIDP may experience an acute initial clinical onset with continued decline within the first 8 weeks and then subsequent chronic progression. And these patients are classified as acute onset CIDP. Retrospectively, it may be crystal clear whether the patient reached their nadir within 4 weeks, which indicates GBS, or patient deteriorated beyond 8 weeks, which is more consistent with CIDP. But in clinical practice, at the early stage of disease, as the disease course is evolving with time, it may be difficult to distinguish a patient with GBS treatment-related fluctuation from patient having a second episode of weakness due to acute onset CIDP. But it is important to differentiate the two because treatment-related fluctuation is ultimately GBS and requires acute management. But acute onset CIDP requires chronic immunotherapy. But how do we differentiate the two? This is a retrospective study investigating characteristics and disease course in patients with GBS treatment-related fluctuation and acute onset CIDP. The study aimed to identify clinical factors that can help to distinguish between these two variants of inflammatory polyneuropathy in the early phase of the disease. 13 patients with acute onset CIDP and 11 patients with treatment-related fluctuations were compared. And the authors concluded that acute onset CIDP should be suspected when a patient with GBS deteriorates after 9 weeks from symptom onset, or when deterioration occurs 3 times or more. And following this retrospective study, a prospective study was conducted. In this study, a total of 170 GBS patients were included. Eventually, 16 were deemed to have treatment-related fluctuation, and 8 were deemed to have acute onset CIDP. We can see here the treatment-related fluctuation in the GBS group occurred within 46 weeks from onset of weakness. And in the GBS group, none had more than 2 treatment-related fluctuations. And based on the summation score of the muscle strength test, patients in the acute onset CIDP group were less severely affected than patients with GBS treatment-related fluctuation. They did not need artificial ventilation, and they rarely had any cranial nerve dysfunction. So to summarize, the diagnosis of acute onset CIDP should be considered when the patient thought to have GBS deteriorates again after 8 weeks from onset, or when deterioration occurs 3 times or more, especially when the patient remains able to walk independently and has no cranial nerve dysfunction. So now the question is acute onset CIDP truly a subset of CIDP, or does that actually represent a distinct condition? So the identification of the node of Ranvier as the primary set of injury in inflammatory neuropathies has led to the detection of antibodies targeting the nodal and the antinodal structures, such as neurofascin, contactin, and Casper. These antibodies give rise to a distinct form of inflammatory neuropathy termed autoimmune nodopathies in 2021, which differs from conventional CIDP. Autoimmune nodopathies share common features such as distal predominant motor weakness, sensory ataxia, and demyelinating features in the electrodiagnostic studies. But each nodal paranodal antibody is associated with characteristic phenotypes. For example, anti-neurofascin antibody is associated with tremors, cerebellar dysfunction, and dysautonomia. And anti-contactin 1 is associated with nephrotic syndrome. So it's really not clear whether some of the previous reported acute onset CIDP is actually autoimmune nodopathy because it is a newly discovered entity. But again, it is important to recognize this entity because it falls under the category of IgG4-related disorders, and they typically do not respond very well to IVIG, but has a favorable response to rituximab. Okay, so just to make things more interesting, I would like to quickly talk about recurrent GBS. So although GBS is generally considered to be monophasic, recurrences do occur, and the recurrent GBS is defined as 2 or more episodes that fulfill the criteria for GBS. But when patients fully recover in between the 2 episodes, a minimum time interval of 2 months is required. And if patients only partially recovered, a minimum time interval of 4 months is required. And the recurrent GBS occurs in 2 to 5% of patients. This paper identified 32 GBS patients with a total of 81 episodes. Baseline characteristics were compared in recurrent and non-recurrent GBS. We can see the recurrent patients were younger and more often had Miller-Fisher syndrome and a milder course of disease. So I guess the point here is not to predict who will have a second episode, but rather to recognize this entity of recurrent GBS. Because again, recurrent GBS is ultimately GBS and does not require chronic immunotherapy. Lastly, as Dr. Brown elucidated, so GBS is disease nadir within 4 weeks, and CIDP is disease progression beyond 8 weeks. What if patients reach disease nadir somewhere between 4 to 8 weeks? And conceptually, this could happen as well. So this case series defined patients who fall between 4 to 8 weeks as having subacute inflammatory demyelinating polyneuropathy, or SIDP. So overall, these patients' clinical presentation appears similar to that of monophasic CIDP, with an excellent response to steroids and a shortened course. Therefore, they seem to be a closer cousin of CIDP than GBS. And most of these patients actually improved fully with treatment and do not relapse at follow-up. And they seem to have an antecedent infection more frequently than do patients with CIDP. So SIDP seems to bridge the gap between GBS and CIDP. So in summary, GBS is a monophasic self-limiting process. Disease nadir is reached within 4 weeks of symptom onset, followed by a recovery phase. IVIG and GBS can be offered to accelerate the recovery process, but about 40% of patients do not respond to initial therapy, and there is no evidence to suggest repeat the same therapy, switching to a different therapy, or adding on steroid is beneficial in severe GBS. GBS treatment-related fluctuation is defined as clinical deterioration after initial improvement or stabilization, and repeat with immunotherapy is rational. In the early phase of GBS, it is difficult to differentiate GBS treatment-related fluctuation and acute onset CIDP, but clinical deteriorations that occur beyond 8 weeks or occur for a third time should lead to the diagnosis of acute onset CIDP. And autoimmune nodopathies can present like acute onset CIDP, but they have their distinct clinical features. So I guess I'm just going to stop here and see whether anyone has any questions, comments.
Well, I have a comment. Dr. Sun, I want to thank you for a very relevant, very practical review of something we see at one hospital or another. We're seeing this at least once a month, which is kind of the expected incidence. And so this is a very practical review of a very common condition. And your talk will either change management or it explains our current management, such as why do we only do 5 exchanges? And you have explained that quite clearly. So I did have a couple of questions. You mentioned the case of GBS that has SIADH. What other non-neuromuscular features are common in Guillain-Barre, or are maybe suggestive of something else, like you mentioned the nephrotic syndrome and the autonomic features that, from my experience or from what I've read, the autonomic features are less common in CIDP and more common in AIDP. What other non-muscular features do you look for?
For non-GBS?
For distinguishing GBS, or what other things are common? I mean, I'm not sure how often I've seen SIADH with Guillain-Barre. I'm not sure if I've actually looked for nephrotic syndrome. Are there things that we should be looking for other than the neuromuscular features that would help us change management or select the right treatment?
Yeah, sure. It's a very hard question to answer. So like Dr. Brown, like you mentioned, dysautonomia can be seen in GBS. And dysautonomia, at times, they are not clear-cut. People may present with urinary or bowel symptoms. And from time to time, we wonder whether this is actually a spinal cord abnormality. It is very hard to distinguish in the clinical practice. Dysautonomia is actually less commonly seen in CIDP. So there's still a matter of debate whether these autoimmune nodopathies are considered CIDP variant. In the CIDP 2010 guidelines, those nodal perinodal neuropathies are considered part of the CIDP or CIDP variant. But the new guideline has taken autoimmune nodopathy out of the CIDP variant. They are considered a completely separate condition just because they do not respond very well to IVIG, and they are actually IgG4 disease, and they respond to rituximab. Not sure whether it makes sense.
How often or when do you check IgG4? Is it
So-
something that what kind of things do you gather? Because once you do plasma exchange, the yield of that test is going to go way down. And once you do IVIG, you sort of contaminated. There's all these antibodies that don't belong to the patient.
Yeah, for sure. It's very pertinent in clinical practice. So for me, when I see a patient who is referred for, let's say, CIDP, I always check these nodal perinodal antibodies. I will tell the patient up front, I will say, since you have received IVIG, if there's a low positivity, I wouldn't consider it abnormal, but it is severely positive, then we would consider this entity, and we may talk about other treatment options.
This is Dr. Wang.
Hi, Dr. Wang.
Okay, so probably I can, make a little bit comments about Dr. Brown's question. The first of all, I want to thank Dr. Sun for the excellent review and the presentation. So come back at Dr. Brown's question. I have two cases, I guess, maybe related to Dr. Brown's question. The one case, the patient presented with SIDP. The patient was admitted to Jewish hospital, and they found out the patient's B12 level was 110. So that's the lowest B12 level I've ever seen. They asked me to do EMG. I did a EMG as an inpatient. That shows classic demyelinating neuropathy. Although, this probably CID before we knew the B12 level says this probably CIDP. They found out B12 level only 110. The patient has been treated. So patient has significant improvement, but not back to normal. But that patient, because the B12 level was extremely low, and she also has factor 5 mutation. She did not get an IVIG, and she has significant improvement. That's this case. You really cannot tell it's a CIDP or SIDP or B12 deficiency. So that's the one. Another one is my outpatient. It's a patient presented with SIDP, and we admitted patient. We did a EMG, shows a classic demyelinating. Patient also had a spinal tap, shows albuminocytological dissociation. The problem with this patient, we check a lead level was sky high. So we found out that the patient his lead level was sky high because he went to indoor shooting once a week. He likes practice shooting once a week, indoor shooting. And since he got a severe lead toxicity, this patient also treated with the IVIG once a month, and he back to normal. But his lead level was significantly decreased because we told him, you cannot go to indoor shooting, and he went to the outdoor shooting. He did not go once a week, he just go once a month because the pandemic, number one. Number two, because the ammunition become very expensive. He said he could not afford it. He went to out shooting once a month only, and his lead level almost back to normal. So he back to normal. We are not sure it's a lead toxicity or SIDP. So this is another case. So that's good. Why I like to make the comments, because I want to medical student and resident know when you diagnose a CIDP or SIDP, you have to look for other treatable causes like a B12 deficiency or even lead toxicity.
Thank you for sharing these two cases, Dr. Wang. Very interesting for sure.
Thank you.
one more comment I want to, sorry, Dr. Friedland, just really quick about these two cases. One more comment I want to make is like peripheral neuropathies, they are never straightforward. And a lot of times we have to make sure the phenotype, physiotype makes sense. So let's say if a patient presents with kind of classic distal symmetric polyneuropathy, then I may think more so B12 deficiency. And if the patient presents with, let's say, motor neuropathy, maybe lead more than CIDP, I guess the phenotype will be very important as well as the kind of disease course, the timeline will shine light into which disease process may be the kind of leading reasons why the patient present with symptoms. Sorry, Dr. Freeland.
Thank you for your comprehensive presentation, Dr. Sun. Could you tell us what do you think is the cause of GBS and CIDP?
I think for GBS, it's always described people had some antecedent event, whether it is some kind of viral infection, stress, surgery, things like that. But for CIDP, people do not always describe an antecedent event. We don't know why CIDP happens. But for GBS, I want to mention one more thing about the international GBS outcome study. So I actually borrowed the slides from the recent ANEM meeting. So this is a worldwide approach. Many different countries have been participated. The goal is to learn more about GBS, and then including whether what kind of preceding infections happen in GBS, and whether genetic polymorphisms could contribute the disease onset of GBS. So this organization has published a few papers from different aspects of GBS. And the goal of this kind of international study is for us to learn more about GBS, including how did GBS start.
Very good.
Are they asking us for samples, or are they offering to do this testing for us?
So samples for sure. I actually just knew this in November of this year. I think there are a few centers in the United States. Pretty much they're asking us to kind of describe, delineate the patient's clinical course, banking all the samples, and then I guess they will do some centralized processing or pull the data and try to answer different clinical questions.
And that's good. In regard to antecedent events, our largest environmental exposure is to the microbes in the gut. And if we knew what the target antigen is, it's relatively trivial to do a blast search, which will compare the primary structure of the target antigen with all the known proteins in the world. And then you can see what the opportunity for molecular mimicry is. If there's a certain, let's say, bacterium that lives in the colon that has a significant homology to some neuronal protein which is targeted in GBS or CIDP, that could be the reason why an antecedent event causes a disease. The best example of that is streptococcus and rheumatic heart disease. But it only requires identifying the target antigen and looking for what similar proteins exist in the world, mostly within our own bodies.
Yeah, good point. Yeah.
That is actually reminds me of a study a few years back where hepatitis E was tested in people who had Guillain-Barre. And hepatitis E is a virus that doesn't cause symptoms, but it can still potentially activate the immune system. And so some of these, like Dr. Friedland has identified some plant viruses that they don't affect humans, but they can potentially set off the immune system just enough to cause some type of an after effect. an autoimmune response to a virus that never caused the trouble in the first place.
Right. We're particularly interested in plant viruses and myasthenia.
So this study, this international study, is there a contact information or anything for them?
They have an official website, and that lists the contact information in there.
Okay, I'll find out what they're looking for. All right. Well, thanks again. Thank you very much for giving us this great review, and it's nice to meet you. If not in person, virtually in person, and hopefully we'll be able to we'll run into each other at an upcoming meeting.
Yeah.
Or we'll come up with our own meeting. We'll have a Kentucky Commonwealth of Kentucky Neuromuscular meeting, and we'll just even if there are only 3 or 4 people there, it'll still be informative. So
Yeah, that would be fun. Thank you for having me.
all right, take care.
Right.
Thank you so much, Dr. Sun.
Thank you.